This episode was powered by Paul Hodge, a financial planner who works specifically with medical professionals. He has helped members of the BrainWaves podcast grow their wealth and manage risk. Learn more about how to secure your financial future at paul-hodge.com.
Receiving a diagnosis of amyotrophic lateral sclerosis is a devastating experience. There is no cure, and unlike many other neurodegenerative diseases affecting the nervous system, the average ALS patient only lives another 3 to 5 years after diagnosis. The only effective pharmacologic therapy we have to offer patients, riluzole, is thought to delay tracheostomy or death by 3 months. And in the meantime, our patients are losing strength, they're losing energy, and they're losing the ability to function independently. So instead of relying on disease-modifying pharmacotherapies to treat these patients, many of which have failed or are still being studied in clinical trials, neurologists work to deliver more comprehensive care. Here on BrainWaves this week to talk about multidisciplinary care in ALS patients, I've got Dr. Lauren Elman, Associate Director of the Comprehensive ALS Center. Thanks for being on the show today, Dr. Elman.
Thanks for having me. I'm glad to be here.
Let's start with a description of your ALS multidisciplinary clinic. When a patient comes to see you, what happens?
Well, when patients come to see us, they either find us on their own because they think they may have ALS, or more often they're referred in by outside neurologists. Usually, the referring neurologist knows that the patient has ALS, but they often haven't told the patient that because ALS is a very difficult diagnosis to discuss with patients. Referring doctors often describe the disease to patients as motor neuron disease. So one of the things that can be very confusing to patients is that ALS goes by a couple of names that mean the same thing: motor neuron disease, ALS, and Lou Gehrig's disease. So when I first see a patient, the first thing I ask them is, so what brings you here today? Why are you here to see me? And that gives me an idea of where they're coming from, what they know already. And the most common answer I receive is, my doctor doesn't know what's wrong with me.
Do you think that's because doctors don't know how to have that conversation initially, or because they actually don't know what's going on?
I think most of the time the referring doctor knows exactly what's going on. It turns out that the diagnosis of ALS is not very hard to make. Usually the doctor is mildly unsure and doesn't want to make the diagnosis just in case they may be wrong. And in addition, it's a very difficult topic to discuss. So what I start with is a very complete history and a very complete physical examination and a review of records. The things that patients complain about most often are focal onset of weakness. About 2/3 of patients present with limb onset disease, which means that they will have weakness in one arm or one leg. The other 1/3 of patients will present with bulbar onset disease, and that is most commonly experienced as a change in speech.
Would you be able to walk us through what kind of services are offered at the multidisciplinary clinic?
Sure. So at our clinic, and this is the pattern at most multidisciplinary clinics, we have quite a large team to help take care of people. So one of the things that I tell people during that conversation about breaking the news is that there will be a team to help them through the disease. And that team consists of their physician, which is me in this case, a nurse practitioner, a research nurse coordinator. We have social work available. We also have a physical therapist, an occupational therapist, a speech and language pathologist, and a dietitian. So all of these people together help take care of the patient with ALS and the caregiver as well. So not every patient sees every member of the team. It depends entirely on what the needs are. Every time the patient comes to clinic, they see their physician. We always check their weight. We always check their forced vital capacity. And depending on what their needs are, they may see physical therapy and occupational therapy. They may see speech and language pathology.
As you can tell, these visits could be pretty long, and patients receive a lot of care during this time. Sometimes visits are as short as just 45 minutes if the patient is stable, and sometimes they last up to several hours. And while there's little research to support the implementation of multidisciplinary clinics for ALS, mostly retrospective papers and anecdotal reports, it's practically a gold standard in the care for these patients. At this point, we'll start to focus on some of the more specific aspects and how this clinic addresses the major issues faced by ALS patients, starting with how you should break the news.
It's very important to break the news about the diagnosis carefully to a patient, and this has to be done in a fairly specific manner. Once I've established a diagnosis in my own mind, I usually ask the patient, is it okay if we talk about what's going on right now? And they always say yes. Patients come wanting to know what's going on. So then we talk about the diagnosis, establish that the diagnosis is in fact ALS. And at that point, we start talking aggressively about symptom management. And that's very specific to individuals. Dysphagia is a fairly difficult symptom to manage. Dysphagia rears its ugly head in a couple of ways. One way is with respect to secretion management, and one way is with respect to nutrition management. It's important to know that secretions come in two flavors. That's probably not the best word to choose when you're thinking about secretions, but it serves a purpose. The secretions that are in the front of your mouth are the liquid, thin secretions that you consider saliva. There's a second set of secretions that are in the posterior pharynx, and those are thicker, more mucus-like secretions. The management of these two types of secretions is different, and sometimes the management of these two types of secretions is actually in conflict. The thin type of secretions in the front of the mouth can be managed by anticholinergic medications. My personal favorites include Robenal, Levsin. You can also use atropine drops, scopolamine patch. If those medications don't work, we sometimes inject Botox into the salivary glands, and usually that's into the parotid glands and the submandibular glands.
Fun fact of the day, the average adult produces 1 to 2 liters of saliva per day, so if swallowing becomes difficult, salivary secretions can be a real problem. The submandibular glands, although smaller than the parotids, contribute the majority of continuously produced saliva throughout the day, about 65% of it, whereas the parotid glands produce the majority of saliva during meals, and submandibular glands become less important.
You worry a little bit about a field effect with Botox injection, so there's a theoretical risk of worsening swallowing function. Now, the thicker secretions in the back of the throat respond to different treatments, and in fact, one of the problems with all of those drying agents that I just mentioned is that if you dry out too excessively, then you risk increasing the thickness of the secretions in the back of the throat. So that's definitely something to watch out for. Now, if someone's having trouble with the thick secretions in the back of the throat, one thing you want to make sure is that they're adequately hydrated, because if people are dehydrated, they will certainly have thicker, gooier secretions in the back of the throat. The other way to treat the mucus-like secretions is with guaifenesin, nebulized medications, albuterol and acetylcysteine, nebulized saline, and again, suction can be helpful. With respect to nutrition, if a patient has severe dysphagia and profound weight loss, we discuss with our patients feeding tube placement. In our hands, about 80% of the people in our clinic with whom we discuss feeding tube placement do elect to have a feeding tube placed.
The increased utilization of supportive care by multidisciplinary clinics has been well described in the literature. Compared to standard neurology clinics, multidisciplinary clinics are more likely to have their patients undergo gastrostomy tube placement, non-invasive ventilation, using devices like BiPAP, which we'll talk about later, and they also more frequently prescribe Riluzole, again, which is the only disease-modifying therapy in ALS. One resource not as frequently utilized among patients seen in multidisciplinary clinics is the hospital. ALS patients just aren't admitted to the hospital as frequently if they attend a multidisciplinary clinic, and they still survive longer than their standard neurology clinic counterparts. I was surprised to see how infrequently gastrostomy tubes are placed and tracheostomy tubes are placed on a nationwide basis.
We have felt through experience that our patients have an improvement in quality of life. I cannot point to data on this. I will say that as dysphagia progresses, a lot of the things that patients tell us is that meals start to take a lot longer. They experience choking. They become dehydrated because thin liquids are the hardest things to swallow. And along with dehydration comes the dreaded constipation, which becomes a real issue for patients. In addition, weight loss will accelerate weakness. So what tends to happen is that patients spend a large part of their day trying to get adequate nutrition, and it becomes a real issue between patients and caregivers. The feeding tube offers a way out of this, and we present it as a quality of life improvement. as you probably know, the two life-threatening issues in ALS are swallowing issues and breathing issues. So we've discussed at some length how we manage swallowing issues. Breathing issues are followed chronically in the multidisciplinary clinic by checking a forced vital capacity, which we do routinely every time a patient comes in. The recommendations are that if the forced vital capacity goes below 50% predicted, that we institute non-invasive positive pressure ventilation. Usually, the first symptoms are nocturnal. So most of the time, people will begin using BiPAP, which is the form of choice, overnight. As symptoms progress, people may transition to using it during the day. So when someone starts using BiPAP during the day and is using it more and more, we do start talking to them about advanced directives and what their choices will be going forward. For better or for worse, people do have to make a choice about whether they want to progress to use permanent invasive ventilation, having a tracheostomy and being permanently connected to a ventilator, or utilizing hospice care. A very small minority of people in the United States choose to be on a permanent ventilator. It's less than 5%. There are many reasons that people do and do not choose to be on a permanent ventilator. It's a very personal decision. In this country, a lot of those factors are financial, to be quite honest, because most insurance companies do not pay for the nursing care required. They pay for the equipment itself, but not the nursing care. For people who do decide that they want to live on a permanent ventilator, the timing of tracheostomy is largely determined by how BiPAP dependent they are. For people who choose not to be on a permanent ventilator, as the disease progresses, we start talking to them about palliative care options and hospice care.
How do you and your nurse practitioner help manage these symptoms of fatigue and anxiety and depression?
I ask about those symptoms every time someone visits. Fatigue is an extraordinarily difficult symptom to manage. We do talk a lot about energy conservation. One of the questions that comes up all the time is they ask about exercise and physical therapy and what should they be doing. It is unfortunately so frustrating for patients to watch themselves getting weak, and they want to exercise their way out of the disease. They want to do physical therapy. They want to get stronger. And unfortunately, our best advice actually is not to do aggressive physical therapy. The way I explain it to patients is that this is a nerve disease and that exercise does not cure nerves. That's oversimplified, of course. What we know is that if you have a muscle that's tired and you exercise it, it will get more tired. So if you think about that you just went running and your legs are tired and you sit down and you rest, then your legs have more energy and maybe you can get up and walk some more. It's the same kind of thing when a muscle is weak. If you rest it, it feels better.
To me, that seems very contrary to the purpose of having PT and OT visits at your clinic.
Right. I'm glad you brought that up, actually. Let me explain what PT and OT do during these visits. So these are not exercises that patients are put through. These are education sessions about proper transfers, a lot of education about stretching. Stretching is very important. So this is an example where an ounce of prevention is worth a pound of cure. One big problem people have is getting a frozen shoulder, because the shoulder isn't moved through its range of motion, and then that becomes painful. So everybody says that ALS is not a painful disease, and in and of itself it's not, but you can have pain as a consequence of immobility. We figure out when, for example, people need to have a power wheelchair. We set that up. We talk about foot braces. All of these kinds of things we consider PT and OT.
And as patients become more symptomatic or more aware of their disease, they may become more depressed or anxious. And how do you manage those patients?
Good question. So I think that depression often happens actually quite early on. It often happens around the time of diagnosis. There's a grieving process that seems to occur. And grief, of course, is normal, and it's a normal reaction. The problem is when grief becomes pathological because it goes on too long. And as we know, pathological grief is a form of depression. The reason that I believe grief often becomes pathological in ALS is because people are forced to grieve over and over again. So they grieve at the time of diagnosis, but really they're okay. They're still walking, everything's okay. But then a couple months later, they really can't walk properly and they need a cane. And now they grieve over the fact that they have to use a cane. And then a couple months later, both legs are weak, and now they really need a walker to walk. So now they're grieving over the fact that they need a walker, and so on and so forth. But the point is that there are these repeated episodes of grief, so they never recover from their grief, and the grief becomes pathological and it turns into depression. And at that point, it really does need to be treated. So we treat early and often. Usually it takes a couple of visits before individuals will acknowledge that in fact this is a problem, because most of the time they say, I'll get over it, and then there's a realization that in fact they won't. But I will say this, the type of depression that people with ALS get is quite amenable to treatment. Anxiety, of course, is a little bit different. They get anxious because they have a deadly disease. They also get anxious related to their symptoms of shortness of breath. There are two ways to address anxiety. You can address it with a daily medication and you can address it with a PRN medication. Patients with ALS really need these PRN medications. So this is not the population of patients to be afraid to prescribe medications to. You must respect that they have symptoms, some of which are organic because of shortness of breath, but really need to be treated because that can feed into itself and people get extraordinarily uncomfortable.
So when it's time to have that end-of-life discussion, how do you approach the patient?
It's not an easy discussion to start. I usually say something like, so it seems as if there's been a progression in your symptoms. Have you given any thought to what would happen if there came a time when the BiPAP was not sufficient to support your breathing? And sometimes they say yes, they have thought about it. But quite frequently, people say no, they have not thought about it. And depending on how they answer is how I proceed. And often it will be with a bit of education. And I will introduce basically the two options, which are proceeding to non-invasive ventilation, tracheostomy with ventilator, or hospice care. And infrequently are people able to sort of say, well, this is what I want to do. Oftentimes, they need to go home, think about it, talk about it with loved ones, and we talk about it the next time. So this brings up the importance of not waiting until a crisis situation to bring this up. And I usually try to mention that. The reason I'm bringing it up now is because we're not in a crisis situation, and it's much, much easier to talk about this when it's not a crisis.
How do you find, I'm trying to ask, in your experience, how do most patients with ALS die? In what circumstances do you see that they pass?
Most of our patients die at home on hospice of respiratory failure. So most patients pass with morphine and in their own beds with their family around them peacefully.
Can you talk about the ways in which you educate families and patients about the importance of having that kind of an atmosphere?
I think that the most important thing we do is talk about this early when it's not a crisis situation. So when you bring this up, you have to force the conversation, and then you have to force it again so that there's some sort of a decision and a plan. And then, to be honest, hospice can be extraordinarily helpful because once you have helped the family make this decision, then when you believe as the physician that it's appropriate, and just to be clear, that is when you believe that there's roughly a 6-month life expectancy, then it's time to institute hospice care. I remain the hospice ordering physician. We partner with hospice to very, very aggressively treat symptoms, keep the patient comfortable, avoid any of those crisis situations. Caregivers often call our nurse practitioner to sort of say, this is what's going on, is this what you would have expected? A lot of times, at the last appointment that I see the patient, they ask me, how am I going to die? What is going to happen? Patients have a fear of suffocation and choking, and I tell them that it won't happen because it doesn't. Morphine prevents those symptoms. Morphine is the best medication for shortness of breath and so-called air hunger. On a positive note, we hear from our caregivers that the deaths are peaceful.
Well, personally, I found this conversation very insightful, and I think I've learned a lot more about ALS and the multidisciplinary clinic. Is there anything else that you'd like to add before we conclude the episode?
Just that I think that we are at a very exciting time in ALS research. There's a lot of interesting basic science research going on, and I think that with all the genetic research that's going on, I think that, believe it or not, we may actually have some treatments to offer over the next 10 years or so please stay tuned.
Again, that was Dr. Lauren Elman from the University of Pennsylvania. Thanks so much for being on the show.
It was my pleasure.
Thanks for listening to BrainWaves today. If you like what you just heard, you can find more related material on the web at brainwaves.me or find us on Twitter at brainwavesaudio. Feel free to contact us at bweditorialboard@gmail.com.
Be sure to check out our iTunes archive for older episodes.
This episode was produced by Jim Siegler. Music by Andy Cohen. I'm Erica Mejia. Join us next time for another edition of BrainWaves.